Thank you all. Good morning, good afternoon, and good evening, everyone. It's my great pleasure to welcome you all to this webinar titled "Overcoming Barriers to Birth Defect Diagnosis and Management in Sub-Saharan Africa." The session has been brought to you by Sub-Saharan Congenital Anomalies Network, SCAN, and Global Health Network. As you know, birth defects or congenital disorders they occur in the intrauterine life, and they can be structural, affecting the child's physical appearance, or they can be functional, affecting the bodily function of the child. And they can be identified prenatally or at birth or even later in life. And according to WHO, an estimated 240,000 newborns die annually within the first 28 days of life. And because of these conditions, and 170,000 and more children succumb to death between the ages of 1 month and 5 years because of these conditions. And the burden of birth defects is particularly pronounced in low and middle income countries, where 9 out of 10 children affected by birth defects reside. And in Sub-Saharan Africa, these conditions pose a significant public health challenge, leading to substantial morbidity, mortality, and lifelong disability. And in resource limited settings, we have lack of specialized healthcare providers and diagnostic facilities that hinder early detection and timely intervention. So in this webinar, we aim to delve into these critical challenges and how we are going to diagnose and manage birth defects in Sub-Saharan Africa. And we have our esteemed speakers and panelists that will discuss the limitation of current diagnostic capabilities, the urgent need for specialized care, and the potential solutions to overcome these barriers. And I would like to extend my sincere gratitude for our esteemed panel speakers. So for housekeeping, this webinar is being recorded and it will be shared on the Sub-Saharan African Congenital Anomalies Network SCAN Knowledge Hub, and we have a closed caption function where you can see the translated speech in subtitles, including in a language of your preference. We have a language there to choose from. And we have a chat function so that you can introduce yourself and where you're from. And there's also a question and answer function where you can post your questions and comments. You may do so anonymously. And we will see your questions will be answered at the end of the presentation. And because we have a number of participants in this webinar today, the microphone and videos have been disabled. And at the end of the session, you might raise your hands so that we will enable your microphone and you can ask through there. So before going to introduction of our presenters, I will like to introduce myself. My name is Samrawit Tegene. I am a medical doctor and I have finished my master's in epidemiology and clinical trials. I'm currently working as a research coordinator at Hararge Health Research, and it's a partnership between Haramain University in Ethiopia and London School of Hygiene and Tropical Medicine. And I'm currently working in a project named SALT Project. We are trying to see the population prevalence and burden of neurological defects in the eastern part of Ethiopia. In using 3 HDC sites. And without further ado, I would like to introduce our first speaker, who is Dr. Justina. So she will be giving her talk on screening and early diagnosis of congenital anomalies in Sub-Saharan Africa, status and progress. So Dr. Justina completed her surgical and pediatric surgical training at Lagos University Teaching Hospital, and she obtained a fellowship of West African College of Surgeons in Pediatric Surgery. She has won the Alinata Nawako Prize for the Best Graduate in Pediatric Surgical Training for that year. She has a passion for developing global health initiatives that addresses and improving access to equitable and quality surgical care in low and middle income countries, particularly for children. Dr. Justina was a key facilitator in the development of the National Surgical Obstetrics, Anesthesia and Nursing Plan for Nigeria. And she currently chairs the committee revising the plan for its second edition. And she is an associate editor for the very successful book named Pediatric Surgery, a comprehensive textbook for Africa. She is also an assistant editor-in-chief of the Journal of West African College of Surgeons and a member of West African College of Surgeons Scientific Committee. She was the facilitator for the scientific working group of the African Surgical Initiative 2013 project, and a member of the technical team and treasurer of the Pan-African Surgical Healthcare Forum. She is a commissioner for the Lancet Commission on Investing in Health and chair for the member of the Global Initiative for Children's Surgery and a member of the G4 Alliance Children's Surgery Working Group. As one of the emerging leaders in global surgery, she continues to mentor and be a role model for students, trainees, and colleagues. Dr. Justina, over to you.
Okay. Thank you very much for this opportunity to speak today. Hello, everyone. Good morning, good afternoon, good evening, wherever you may be in the world. Today, I'll just be giving a very brief overview on screening and early diagnosis of congenital anomalies in Sub-Saharan Africa, the status and progress being made, and a little bit on future trends, directions. Samrawit has talked a bit about this. Congenital anomalies, like we all know, primarily are abnormalities that arise during embryonic development of the baby. And these defects are typically detectable before birth, but sometimes may not be detectable before birth until after birth. And they may be associated with functional impairments. Now, these congenital anomalies can severely, in fact, impact on the individual's physical capabilities, their cognitive, resulting in resultant cognitive impairment, and also ultimately could result in mortality. Congenital birth defects occur as a result of a complex interaction between genetic factors such as genetic mutations and chromosomal abnormalities, alongside environmental factors such as maternal nutrition, drug exposure, and infections occurring in the mother while the child is still in utero. Congenital anomalies have been documented to be the 5th leading cause of under 5 mortality globally, and that shows us that they have a very huge impact on morbidity and mortality within that age group. They account for about 9.4% of under 5 deaths all around the world. And in 2019, there were 8.5 documented new cases of congenital abnormalities. Most of these anomalies are actually surgically correctable. Now, when you come down to Sub-Saharan Africa and you try to look at the burden of congenital anomalies, really there are very limited studies. Most of the studies that are available are single institution studies, and there aren't really very robust birth defects registries that exist within the region. Most of those that exist are still in the infantile stage. And there's also inadequate data collection, and surveillance systems are fragile within the region. So we do not actually know the exact burden of congenital anomalies in Sub-Saharan Africa. But what we know is that they account for about 7.5% of neonatal deaths within the region, and 38% of deaths from congenital anomalies worldwide occur within the region, and 30% of all new cases of congenital anomalies are also found within Sub-Saharan Africa. In addition, when you look at the global burden of severe congenital anomalies, a significant proportion of that happens within Sub-Saharan African region. Now, just to give us an idea of the types of anomalies that occur within different parts of Sub-Saharan Africa, for East, Central, and Western Sub-Saharan Africa, the types are essentially the same. There's just some difference in ranking of the burden of these conditions between Southern Sub-Saharan Africa and the other regions. So if you look at East, Central, and Western Sub-Saharan Africa, the commonest you'd find is congenital heart disease, same as for Southern anyway, and also other congenital birth defects. They that have been grouped that way, they come second. But then subsequently you have neural tube defects, digestive congenital anomalies, and musculoskeletal limb defects, forming the top 5 congenital anomalies in the other regions besides southern Sub-Saharan Africa, where coming after the other congenital birth defects, we have musculoskeletal and limb defects, Down syndrome, and then digestive congenital abnormalities. I mean, this could actually help with planning, resource planning, and human health and healthcare personnel development when you're looking at specifics for these conditions. Now, just to give us just as a reminder, when we talk about screening for congenital anomalies, it is really a systematic process of identifying these anomalies, when they occur. And the aim of screening is to ensure that there's early detection and management with early intervention, and also to guide parental counseling for decision-making concerning these children, whether they're detected prenatally or postnatally. And the early detection allows for better planning of medical care, including in utero treatment if it's available, and planning for specialized neonatal care. Screening also plays a very significant and crucial role when it comes to reducing morbidity and mortality that's associated with congenital anomalies, and also especially long-term disabilities. Now, screening could occur prenatally and postnatal, and I'm sure most of us on the webinar were already aware of that. Now, looking at Sub-Saharan Africa specifically, right, unlike in other parts of the world, the common screening methods that are available include for prenatal screening, fetal ultrasound scan. In other climes, there are so many other screening methods that can be done, both invasive and non-invasive. But in Sub-Saharan Africa, the most widely used method is the fetal ultrasound scan. And this requires well-trained healthcare workers to identify potential anomalies. And it's valuable for detecting major anomalies. Its availability, however, is restricted due to cost and the expertise needed, like I said. And it's been estimated that less than 20% of women have access to this particular screening method in some parts of Sub-Saharan Africa. Now, postnatally, the most widely used method is clinical examination, which sometimes is complemented with use of picture toolkits, especially at the primary care level, to assist the healthcare worker identify specifically the condition he's dealing with. It also requires very good training to ensure that the healthcare worker is able to identify the anomaly through physical education. And although this clinical examination of newborns should be standard practice, a number of times, a number of anomalies are missed at birth and in the early neonatal period because the healthcare personnel attending to the babies simply lack the appropriate skills and the capacity to carry this examination. And also, in many parts of Sub-Saharan Africa, most births are done out of hospital with traditional birth attendants. And also, so that limits the extent to which this clinical examination can also help with identification of congenital abnormalities. And the other common screening method is the use of pulse oximetry, and this has been the subject of a number of studies and initiatives, and it helps to detect critical congenital heart disease in newborns. Although concerns exist about its accuracy when dealing with darker skin tone babies, but then it's been used to detect congenital heart diseases early. So these are the main screening methods that are commonly used in Sub-Saharan Africa, unlike in other parts of the world where patients have access to things like fetal echocardiography, fetal magnetic resonance imaging, and also invasive screening. These also exist in some parts of Sub-Saharan Africa, but the prevalence is very, very limited. And usually it's out of reach of most of the population that need it. So just riding on what I had been saying before, there's very limited access to congenital anomaly screening in Sub-Saharan Africa. In most parts of the region, it is not available. Like I mentioned earlier, in some parts, just less than 20% of women have access to fetal ultrasound scan. And also where there are, when a lot of times when government starts implementing some programs to enhance screening for congenital anomalies, it's not equitable, meaning that most of these programs are usually within the urban areas, and most large swaths of the population that live in rural and suburban areas are not able to access these programs. And there's also limited scope, which is part of what I had discussed earlier on, where typically it's the very basic screening methods like clinical examination and fetal screening and pulse oximetry that are emphasized. The more technical screening methods usually are not available within Sub-Saharan Africa. And when you talk about equipment and personnel, most of the equipment they are lacking, and where sometimes the personnel don't have the adequate requisite skills to properly execute the screening methods. There are also limited surveillance systems, and so a lot of patients still fall through the cracks at times when they could have been detected even beyond the neonatal period. Now, where some of these methods are available, including even what we consider could be basic, like a fetal ultrasound scan, out-of-pocket costs keep them out of reach of most of the population that need them. And of course, ignorance also plays a very significant role in limiting access and usage of these screening methods among people, among the population. Now, there are several institutional, national, and regional initiatives that are ongoing to address gaps in congenital anomaly screening. The World Health Organization and other organizations have continued to promote integration of congenital anomalies into maternal and child health programs. And this particular network that has put together this webinar today is one that also supports and carries out a lot of activities towards increasing screening and also ensuring that congenital anomalies result in reduced morbidity and mortality. But still, most of the programs that are ongoing within the region are siloed. They are within institutions, and there isn't much integration or collaboration between different organizations that work, and therefore the impact is not as strong or as extensive as it could actually be. What is needed currently would be increased training to ensure that the screening is done properly, and there's better skills when it comes to congenital anomaly screening, better integration of congenital anomaly screening into existing maternal and child health programs. And if this is done, it would go a very long way into increasing the early detection of these conditions, and of course, early referral and treatment with much better outcomes for for children that present with congenital anomalies. And considering how extensive maternal and child health programs are within the region, it will be highly impactful. Integration into school health and nutrition programs could also help to detect those anomalies that are missed during the neonatal period. And as there's continuous and continual advocacy for school health programs, especially at the primary school level, that will be a very good avenue for detecting most of these anomalies. And this is one of the things that we continue to advocate for, even in the Global Initiative for Children's Surgery, to make sure that congenital anomaly screening is incorporated into school health programs. And this will limit late detection of some of the anomalies that we see, like having 13-year-olds, 14-year-olds coming with hypospadias or undescended testes, which could have easily been detected much earlier on in life. There's also a need for screening to be integrated into health policies. It's been said that what is not captured within a health policy will not be funded, and if it's not funded, it will not be implemented. So for most countries, where if you take a review of the child health policies that exist, you may not find much on screening for congenital anomalies within them, even though they are child health policies. So there needs to be an advocacy and an integration of congenital anomaly screening strongly within child health policies. And again, community engagement and community education is also very vital and very important in order to reduce ignorance, help with identification of these conditions, even for those that do not have access to healthcare facilities, you know, and also to remove some of the stigma and the wrong beliefs and notions that surround these conditions. And of course, use of innovative approaches. This could help with improving the skills of and the interpretation of findings by the healthcare workers. For example, like using AI to help better interpret ultrasound scan, use of point-of-care ultrasound scan as well, you know, in when doing health campaigns, and also when attending to these patients, even in hard to reach regions within Sub-Saharan Africa. So overall, while there has been some progress in establishing congenital anomaly screening and surveillance systems, significant work is needed to ensure equitable and effective screening across the region, with a focus on integrating low-cost scalable technologies and community engagement to improve outcomes. Indeed, addressing the burden of congenital anomalies, especially in resource-limited settings like ours, requires significantly strengthening early screening, improving surgical access, enhancing post-operative care, and promoting equitable distribution of medical resources. I think I'll just stop here, and then I'll give room for the next speaker to continue. Thank you very much.
Thank you, Dr. Justina. This was a very informative presentation on your part about the screening and early diagnosis. And now we will move to Joyce, and we will hear from her. And we have Joyce today with the title Perception, Experience, and Meanings attached to the externally visible birth defects by parents of children with birth defects, healthcare workers, and community health extension workers in Uganda. Joyce is a counseling psychologist with midwifery background with over 18 years of experience. She is currently responsible for coordinating, supervising, training, and supporting surveillance nurses and midwives, and that implement birth defect activities in Kampala hospitals, Uganda. And she has had this role since the inception of birth defect in 2015, and she continues to play as the project is rolled out to other parts of the country. Welcome, Joyce, and thank you for being part of this webinar. So we are ready to share your experience with us.
Thank you very much for giving me the opportunity to share with the team. We are so happy as an institution and as an individual to be part and parcel of this important meeting. Thank you very much, Dr. Samrawit, for introducing me. I'm going to share with the team the perceptions and meanings attached to externally visible birth defects by parents or children with birth defects, healthcare workers, and community health extension workers. That is a study that was carried out in Uganda. As we are all aware, birth defects are a significant global health issue, and it is affecting millions of children annually. And we're all aware that unexpected 8 million babies, that is around 6% of worldwide births, are born with birth defects each year. In Uganda, if we come to our country, hypospadias and talipes are the most common birth defects, and that is one of the, if you can look for that, it was also published somewhere in 2019. And since 2019, we have carried out a birth defect surveillance system, and it has been implemented in 4 hospitals. Those are the hospitals, 1 government hospital and 3 not-for-profit hospitals and in Kampala, Uganda. The objective of this main study is to determine the birth defect prevalence and identify any associations between maternal use of antiretroviral therapy, those are common medicines in early pregnancy, with incidence of birth defects. When we are talking about the birth defects that we are talking about, where people had their perceptions and meanings attached, we have birth defects of interest to this study. And I will not go through one by one, but in groups, we looked at malformations of the central nervous system. We also looked at malformations of eye and ear. We also looked at orofacial clefts, abdominal wall defects, malformations of the digestive system, imperforate anus, and malformations of genital organs. And lastly, but not least, we looked at the malformations of limbs. Those were the birth defects of interest to the study. That under this main study, we carried out a qualitative sub-study, and this qualitative sub-study was conducted from October 2022 to May 2023. And the objective of this sub-qualitative study was to explore perceptions, experiences, and meanings attached to those externally visible birth defects that I've just discussed. The populations that we looked at in this sub-qualitative study were parents, and these were mothers or parents or stroke mothers whose babies were born with externally visible birth defects. We also looked at healthcare workers who provide care for such babies, and we also had to look at to get community health extension workers, and we are calling them CHOOS, from communities where such babies reside after discharge. So these parents, I'm talking now about the participants who are reading these, the criteria. We had participants who were mothers of children diagnosed to have an external birth defects identified from the case control study, where the inclusion where they were 18 or above, delivering from participating hospitals. They are the ones whom we put in and were willing to participate. And these were contacted within 3 months of delivery and to schedule an interview. So we also included healthcare workers. These were representing different cadres from different hospitals. These were nurses, midwives, and doctors from 1 government hospital and 3 faith-based hospitals, with at least 2 years experience in caring for babies, for such babies, and working in any of the hospitals. The inclusion criteria for those community extension workers, these were people who are really in the communities, and they were helping patients and vulnerable populations to get government health care and social service programs and working voluntarily. So, based on the communities they served, also the inclusion was that we really put them because of the communities they served, and these were selected by the local councils to make sure that we include the right people. And these included 1 to 2 community health extension workers from each of the divisions of Kampala, and these FGIDs comprised 6 to 8 discussants. So, data collection methods. We really carried out in-depth interviews with parents, as we already said, and this was face-to-face in Uganda. We also had key informant interviews with healthcare workers, and it was also face-to-face. And like I said, we also focus group discussions with these CHOOS who worked in the communities. And all these participants were provided with visual references during the interviews so that they could be able to look at the pictures. And we also, all the interviews and discussions were audio recorded with permission from the participants for purposes of having complete record of interviews. How did we analyze data? We audio recordings from participants were transcribed and translated into English for analysis. We also had a thematic analysis, which we used to do the analysis. Transcripts were uploaded to Atlas TI, that software for systematic detailed coding, data management and analysis. And also transcripts were coded with a specific focus on identifying emerging themes. And the research team also, we held interactive meetings to refine those codes that we had got and to agree on some of the themes. And this really helped us enhance on the analysis process. Those were the results. If we look at the results, like I said, we had the mothers, and if you look at the left side, the social-demographic characteristics of mothers, these were 30 in number. Very fast, less than, majority were like more than 30 years. And when it came to, yes, the median, they were 27, around 27. And then education level, the ones who had the highest education level were the ones in secondary. Half of them had jobs, and yes, majority of them were married. If you look on the right, those are the birth defects that were really got. The mothers, their babies had such birth defects, and majority of them had hypospadias, followed by talipes equinovarus, and the rest of it. The social demographics of the focus group discussions, those are the characteristics. They were 30 in number, and majority were like almost half. They were 50%, more than 40 years, 50%, less than 40 years, they were 50, as you can see it. And half of them were male, half of them were female. Majority were married, followed by those ones who were single. And when it came to education level, we had 53% of them being in secondary, and those were the locations. And when it came to the key informants, there were only 10, and we had physicians, they made a percentage of 20%. Faith-based hospital midwives, they made 50% of key informants. One government midwife, that was 10%, and independent surveillance midwives were 20%. I'm continuing with the results. And when we looked at the themes, these are themes that really came out, and the key emerging themes were perceptions about birth defects, their experience with birth defects, and barriers, social challenges, and reactions towards birth defects. When it came to perceptions about birth defects, awareness of major external birth defects, their causes and prevention, as well as trends. In general, these externally visible birth defects were perceived differently by different participants. These are mothers, children, and healthcare workers. They held various views and understanding, as well as meaning attached to major external birth defects. And participants, especially the parents and children, were not aware of such defects that I showed you in the beginning, their causes as well as prevention. And even to our surprise, a few of the health workers did not know the causes and prevention. Common perceptions about causes and birth defects by majority of mothers and those choose, they thought these were hereditary, not very different from other whatever. Lifestyle choices, those things, environmental factors, and other additional causes included actions by parents such as promiscuity, use of certain family planning, and all those vaccines and illnesses. And as well as self-administering or mixing of multiple medicines to herbs during, that is how they perceived the birth defects. Those were some of the quotes from our parents. I might not go through them, but yes, those were some of the quotes. And I can just quote, maybe read one. Due to lack of awareness about birth defects in the community, some think that this child was affected by the mother's promiscuity when she was pregnant, and others agree that it was God's plan. most community members will think around witchcraft, as they do not have information around these birth defects. So that is one of them. When it came to health workers, they almost had the same answers, but the reality is, to some of them, the causes of birth defects were not clear and not known. So one of them just said, the cause of birth defect, I can't tell because some come as new things and studies. So that is that. When it came to experiences, now, as I was saying, mothers or parents really reported experiencing pain and sadness, as well as financial constraints and strained relationships. So those are some of the quotes, and some of them aired out that they were blamed for having such a child, and they were considered BD. These birth defects were considered uncommon and seasonal, or even a curse to some of them. But we also had some people, the experience they shared was like they appreciated the counseling and drew comfort from believing that their baby's conditions can be corrected. A few mentioned getting insufficient counseling and information about birth defects. When it came to experience of healthcare workers, choose, I'm continuing, these lacked information regarding external visible birth defects. The majority of CHOOS shared the experience of being unable to provide necessary information and counseling support to affected mothers and families residing in their respective communities. And the reality is, a few health workers shared the same. I'll not go so much into the quotes. So the reality is, even CHOOS also had no idea on where to refer such babies once got in the communities. Some of the barriers that really were pointed out, the fact that majority of mothers admitted facing financial constraints and relationship strains with their male partners, they shared that, and other common social challenges included, they were not able to access services for such babies, and it was a challenge. And it was also seen that isolation of such babies is actually occurring. And in the communities, you can even, these babies are deliberately hidden from the community. So one even of them quoted, accessing appropriate care remains a struggle. There is certain lack of support for families like ours, that is a mother. Some of those things were there. And other things that healthcare workers, this one suggested the need for specialized support services for affected family, including social, financial, and emotional support. So those are some really of the burdens, the barriers that are really occurring, including support for those families that are really affected. There's no financial support, there's no emotional support. So we cannot do anything unless we put in those things in place. And majority of participants suggested providing early pregnancy scans, avoiding of herbs and prescribed medicine as BD prevention strategies, and this was by all. So as I conclude, we can just know that lack of awareness about birth defects highlights a significant gap in birth defects public awareness that could be critical for improving early detection, understanding risk factors, and promoting preventive measures for birth defects. And when such mothers who give birth to such babies are really stressed and stigmatized by the family and communities, therefore, there is need really to support these people psychologically, emotionally, physically, and all those things. And really having a child with a birth defect presented challenges for parents, healthcare workers, and community alike. Therefore, we are recommending that there is need to enhance education and awareness through targeted health education programs to empower healthcare workers and communities to support affected families better and encourage preventive practices where possible. We also need to equip health workers and CHOOS with skills to effectively communicate, counsel, and support affected families and their communities. Because if these people are not well equipped yes, it is going to be a barrier. Nobody can know about birth defects. And we also need to have specialized follow-up services, including early health care access, medical surgical care for children born with birth defects. And this would benefit parents and their babies, as well as the wider community. I acknowledge all those people that are there, my institution for giving us a chance to work on this project. Also, the CDC people who are really funding us, those names are there, even those people who have supported us right from the beginning. We are so happy. The parents, the participants, and all partners in this project. Thank you very much for listening to me.
Thank you, Joyce, for your very nice presentation. And I believe that knowing the community perception and the perception and knowledge of the healthcare providers is very essential, because addressing those gaps might lead to a timely intervention for birth defects that are at least externally visible. Thank you again, Joyce. Before we proceed to our next speaker, I would like to remind you that we have a question and answer feature in the bottom of your screen. So you can pose any question that you might have for any of the speakers, and we will address them at the end of the presentation. And now we are going to proceed to our third speaker, who will be presenting on human-centered design of user-centered model of service delivery for families of infants with major congenital abnormalities in Kenya. So welcome, Dr. Audrey. So Dr. Audrey is a medical doctor, and she's currently serving as a neonatologist at the Moi Teaching and Referral Hospital, Eldoret, Kenya. And she is teaching undergraduate and postgraduate students at the Moi University School of Medicine. She has expertise in neonatology, pediatrics, and child health. And she has championed and implemented various key projects aimed at improving pediatric newborn health outcomes. And she is very passionate about neonatal care research, teaching, mentorship, and advocacy. She has great interest in research, especially in neonatology and child health. Welcome, Dr. Audrey, and thank you for being part of this webinar. So over to you.
Thank you. Thank you so much. And I'm going to present a presentation on just a study we've done on a human-centered design of a user-centered model of service delivery for families with infants with major congenital anomalies in Kenya. This is a sub-study of another study called Mango study, which is a pharmacovigilance study. So those are just the list of the people who are part of the study. So just a few background is that the congenital anomaly, as we've all been told, is a major cause of morbidity and mortality in children, affecting around 1% of live births. And we all know that from WHO, major congenital anomaly are basically anomalies that actually have either medical or cosmetic significance. The Mango study, of which this study is a sub-study, is a study that actually was looking at the epidemiology of major congenital anomalies in Kenya, and also looking at the potential causes of congenital anomaly, including the association with HIV and antiretrovirals. It's actually a pharmacovigilance study, but during the course of the study, we actually realized the need to do a sub-study on congenital anomalies. As a methodology, usually what happens for the Mango study, women are enrolled in two ways. We have the C1 enrollment, which are women who are enrolled in the antenatal clinic and followed up prospectively. And then we have the C2 cohort, who are women who have delivered within the hospital, which is data that is collected real time and retrospectively. And then once all the children who deliver in the hospital are actually examined, and the ones who are found with congenital anomaly are enrolled into what we call the C3 cohort, who are children who have all congenital anomalies. And then the ones who don't deliver within the hospital but are enrolled from C1 cohort are actually, we do a verbal autopsy on phone using a WHO tool. And then the study team goes to the community and examines them for any surface, any congenital anomaly. And then if they're found with a congenital anomaly, they're also enrolled into C3. And our data sources are usually the mother-to-child booklet. We have the paper files. We have also the The data is also linked, the ones who are HIV positive, their data is linked to the AMPATH medical record system. And then for the ones who are diagnosed with a congenital anomaly, there is photos are taken of the surface exam. And then a group of experts, including a genetic specialist, review the babies. And then from that, we're able to classify the children using ICD-10 coding. And then data is then analyzed and then put also in the multi-regional analysis in the IDEA data set. So as I said earlier, initially it was a pharmacovigilance study that started as a hospital-based surveillance. And then in the process, mothers, after we identified the problem, we asked ourselves, these mothers and their children are not getting good care. So we asked ourselves, what are we going to do about it? And then we realized we looked at the literature and found that there was paucity of data regarding the children with congenital anomaly, what are their care needs and what challenges are they facing. Hence, we applied for a grant and we were able to get the grant. The aim of our study basically is to develop a user-centered model for service delivery for these children. With the first aim was to explore community perception and lived experiences and the care needs of these families and their infants. And then the second aim was to develop a service delivery model optimized to meet the needs of this family. So in terms of methodology, we used a design council double diamond framework to guide our data collection, and which has four phases. The discover phase. During the discover phase, we did in-depth interviews with parents and both mothers and fathers of infants with major congenital anomalies that had been enrolled in the Mango study, and then were able to get their experiences and the care needs. And then in the define and develop phase, what we did, we conducted participatory workshop for parents and healthcare providers. And from these, we were able to brainstorm and define what are the possible interventions that would make services more person-centered, and also found out what is their hypothesis in terms of what would be, how that would work. And then in the discover phase, what we did is that we also asked them to prioritize, to reflect on those on the needs, and also to prioritize the unmet needs, and to look at how are we going to best implement them based on the cost impacts on cost and opportunities. And then the workshops actually concluded with a next step where we using the delivery phase of that framework, and we're able to prioritize what interventions are necessary in order to have this patient-centered model for delivery of care for these children. So for our results, the study was conducted between August 2023 and actually it spilled over to May of 2024. We had a total of 31 participants, 21 women and 10 men, 10 fathers. And then also we had a total of 19 healthcare providers who participated, and they range from mid-level to high level. We included up to pediatric surgeons, neurosurgeons, fetal-maternal specialists, counselors and child life support nurses, and also nutritionists that came in. So for among the children, which I won't go into a lot of details, is that we had 23 children because one parent had twins, and there was a slight male predominance, and in terms of gestational age, most of them were term babies. So some of among the children, the 23 children, the major abnormality was talipes equinovarus, and then we also had quite a number of children with cleft lip and cleft palate. And then also we had all the other anomalies that you can see from the table. We had a few with hydrocephalus, we had a few with combination of hydrocephalus and spina bifida, and a few with disorders of sexual differentiation, actually one. So from what we gathered, we developed, we had a psychosocial model, and then which had 4 domains. And among the 4 domains, we had the individual domain. In the individual domain, some of the themes that came out is the psychological and emotional impact. We had stigma and financial challenges. And then in the family domain, there was an aspect of psychological also and emotional impact on the family. But in addition, there was also the issue of involvement of partners and the importance of shared responsibility. In the healthcare domain, what came out strongly was the importance of early diagnosis and the importance of supportive care, and including counseling and child life services. And then health education, not only to the parents, but also training of the healthcare providers, because both the participant and even the healthcare providers felt that there was a shortage of knowledge with regards to congenital anomalies. And then there's also an aspect of integrated care clinics, and something that came out also quite strongly. Some parents felt like after discharge, they are left to go on their own. And also the care providers emphasize the importance of post-discharge care, just having a whole paradigm shift in the healthcare system so that it goes beyond the hospital setting. And then in terms of community and societal domain, there was an issue of community perception and stigma, and the importance of community support, and also the importance of community health education. So among the individual domain, what came out is that there was a lot of intense emotions around after the diagnosis, which was accompanied by a lot of fear, shock, and anger. And the reactions actually varied based on gender. And a lot of women actually had fear and sadness and anxiety, and yet men actually had a lot of shock and anger. And what happened is that women had a tendency to cope better and falling into religion and than the male. The male actually, we had quite a number who said they went into alcoholism. Some said they were they were so stressed they were about to be admitted into a mental hospital, and some men actually said they are about to leave their families and run away and divorce. Then we had the issue of financial challenges. So in terms of that domain, some of the things that came out. So one mother who had a child with hydrocephalus said, I felt really bad and shocked. I almost had a heart attack. And every time I arrived in hospital, I was sweating and I sometimes forgot. One male spouse actually said that the diagnosis is really draining to the mothers, both from mentally, psychologically, and health-wise. She said just everything. And then in terms of, some of them blamed themselves. One said, I was ashamed and was in regret and wished I knew earlier. Actually, one said if she knew earlier, she would have gone for an abortion. Then one of them was in denial and said, with the child with Down syndrome, said I actually refused the diagnosis every time she was told. Then there was a big issue around finances individually and saying that the whole diagnosis made it hard for them to even buy medication and even just to get a balanced diet and get to clinic. And one of them actually said that advocated that the centers should be brought closer to their villages, because at some point she stopped coming for care because of lack of transport. And NHIF is our health insurance system. And one of them said, who had health insurance, actually said it really helped, and she stopped asking for it, reduced the need to ask for money from people. In terms of family, what came out strongly is that the diagnosis really affected the entire family. And some parents actually concealed the diagnosis from the siblings because of that. And there were instances of abandonment and strained relationship. And from this, what came out strongly during the participatory workshop is the importance of sibling visitation and family therapy during the care of these children. It's important that we actually involve the family from the beginning in terms of counseling and also therapy, and allowing sibling visitation, and having policies that allow for family visitation. So some of the things that were said, there's one that said that after the scanning, I called the father, and the father denied and said that the child was not his. One said that sometimes it leads to divorce. Actually, that it led to divorce, and some parents were feeling angry and also feeling cursed. And then in terms of family support, we've already said they all, from the participatory workshop, they say that it's important to have, I think, which I've already said, family therapy and sibling visitation. And then the other part about it that they actually mentioned is the hospital part. And there was a lot of complaint about the need to strengthen early diagnosis in order to prepare the families. And then there was parents actually complained quite a bit in terms of lack of clear and comprehensive information from healthcare providers. And the healthcare providers during the participatory workshop, some of them said, especially the mid-level, they said they felt they had inadequate knowledge and they were ill prepared to be able to counsel, and even them, they were not ready for the congenital anomalies. And then there were a lot of challenges in terms of the clinics and the surgeries and sometimes medication availability. There was a lot of mention on the need to prioritize family-centered care in terms of to grant families emotional connection and grant families the necessary time and space that they can, so that they are able to offer nurturing care to their children. And they said the issue that there should be private spaces in the hospitals and places where they can be able to just stay with their families and provide the support that the children need. So in the issue of postponements, one of there were positives and negatives. One who got services actually liked it and said a male partner who said that his child got treatment immediately. Then there was one who actually said when a child is ready for surgery, it should be performed without delay. It's torturing us mentally and physically. Then when you come here, you are told that it's either full and then or that you go back home. That it is something that is traumatizing. Such a father who had a child with cleft lip said that, and then they complain about the issues of long queues and the importance of having also talked about the issue of shortage of staff, that it would be better if the doctors were more, and it would be better if they informed you earlier when you it would be better if they informed us earlier on when to come, so that they don't lack the doctors. Then there was the issue of how we run our clinics, and I think one parent actually said that the clinics are really generic. I'd say when he comes to the clinic, at times he gets the doctor, and when they see how the patient is and ask you a few questions, and then you go back, just that he was expecting they go deeper and ask him more questions and tell him something about the related treatment. So a way in which we need to change the way we handle patients and how we deal with children with congenital anomalies. And then there was an aspect of supportive care that came out strongly, the need to educate about congenital anomalies during pregnancy. Actually, one of them reported that the way that we have HIV training and HIV counseling during antenatal care, that we should also be talking about congenital anomalies. And that came out several in the in-depth discussion. And then also they need to create support group, and that's including WhatsApp group. And some of them said that, and they need to decentralize services, and especially occupational therapy and support care services. And also, I think we've already talked about the importance of education, which came out quite strongly. And I won't read through that, but I think what came out strongly and we have already tried to start implementing is having a lot of support services and WhatsApp groups, and also just having a more holistic care where it's a place where they go and get a one-stop shop where they can go and get all the services. They actually say, some of them say that they come on a Monday for like a neurosurgical clinic, and they have a Wednesday to do a cardiology clinic, and they have a Friday to come and do like something else. So I think that actually is something that we need to consider, because most of these children with congenital anomalies have a multidisciplinary, like a multisystemic disease. And then in terms of the community, there was varied opinions. There was some that felt the community was supportive, but there's some that felt that there was lack of community support, with families feeling that they were left out and to just be on their own. There was issues of stigma and exclusion of the family, and instances of abandonment, including one who said even their own mother abandoned them because of their own maternal mother actually abandoned them because of having a child with congenital anomalies. And so what came out during the participatory workshop, that there is actually a need for community awareness, advocacy, and education to just put aside the misconceptions and misbeliefs, and also to just be able, so that they're able to know what are the real causes of congenital anomalies, and to be able to be supportive. So one say that most of the people, a mother who had a child with Down syndrome, say that most believe it's a curse. And then one of them who had a child with cleft palate and cleft lip say that most will backbite as they do not understand stigmatization is there, just like HIV cases. And another one said that they should create more awareness about these anomalies, that people should learn and stop this stigmatization. And then they also talked about so there was a lot that we found from the study, and a lot that we are going to, I think, from the published paper that we can share from both from the first aim and the second aim. And the second aim, we got quite a bit that we are trying to look at, since we are able to prioritize what are the priorities and what needed. What during the workshop we said what needs money, what doesn't need money, what can be implemented immediately, what can be implemented in the midterm, and what can be implemented in the long term as you look for funds and the rest. So in conclusion, what we found from the study, that our study highlighted that there are many challenges that are faced by families with children with major congenital anomalies in a resource-constrained setting. And for us to effectively address these challenges, we will require to conceptualize intervention across socio-ecological domains to create more personal-centered services for this population. So I would like to acknowledge the people from the Mango study, which I have already, which are listed there, the East African idea. I also want to acknowledge SCAN for actually sponsoring the website and also just helping us to actually refocus on congenital anomalies and the hospital together with the AMPATH consortium. Thank you.
Thank you, Dr. Audrey, for your nice presentation and for giving us insight into what's going on in the study. Thank you again. So I'd like to remind you again about the question and answer feature at the bottom of the screen, your screen, so you can ask any of our panelists today. And now we will go to our last presenter for today's webinar with the title of Birth Defect Diagnosis and Management in Sub-Saharan Africa, Dr. Tadesse Gure. He obtained his medical degree and specialization in OBGYN from University of Gondar, Ethiopia in 2010 and in 2016. Respectively, he completed a subspecialty in maternal and fetal medicine at Haramaya University, Ethiopia in 2024. He began his career as a lecturer in the OBGYN department at the University of Gondar, and subsequently he took on the leadership position first as the postgraduate coordinator and later as the head of the OBGYN department at Haramaya University. Currently, he is serving as an associate professor of obstetrics and gynecology at Haramaya University, where he also practices as a subspecialist in maternal and fetal medicine at the affiliated referral hospital. His dedication to academics and clinical practice is complemented by his involvement in various research projects, and he looks forward to continuing his journey in academics, clinical practice, and research, striving to make meaningful contributions to the field of maternal and fetal medicine. Welcome, Dr. Tadesse. Now over to you.
Thank you, Dr. Samrawit, for generous description. So I'll go with my presentation. So I'm going to say something about birth defect diagnosis and management in sub-Saharan African countries. So I do have an outline to discuss about background of birth defect, what's the diagnosis, how do the defect in these African countries, of birth defect in this challenge in sub-Saharan Africa countries and African countries. So as a background, birth defect is a structural or functional. It can be in diagnostic modality or at first while examining newborn examination, or sometimes later after infancy or during infancy period. And it has first group of disorder, gene defect or chromosomal disorder or multifactorial inheritance or environmental teratogens. And benefit of diagnosis of this birth defect, or we can see the key factors about by WHO in 2023. This birth defect or congenital leads to the days of 240,000 newborns in the first 28 days of life during every year, and also leads to the days of 170,000 children between the age of 1 month and contribute to the long-term disability. And 9 of 10 children born with serious congenital disorders are from low and the middle income countries like sub-Saharan African countries. And the most commonly identified congenital disorders worldwide is an NTD or neurological defect, heart defect, and a Down syndrome. Diagnosis of the congenital anomaly can be made antepartally or antepartally at birth or in the infancy period. So it's the benefit of doing diagnosis during prenatal period or during antepartum period has many benefits than doing at birth or later infancy period. So this will help us to counsel the family, what's found or later. Is it treatable or non-treatable? We'll counsel the family or discuss with the family. And family, for example, if the baby has anencephaly, so we'll give an option of termination of for the family, or they may decide to continue the pregnancy even if there's a little congenital anomaly. They may decide to continue the pregnancy to see the baby after birth, or there are options of intrauterine therapy. So providing them intrauterine therapy so that the morbidity and mortality are in this intrauterine therapy. For immediate surgical have duodenal atresia or neural defect, which is not treated in the treated immediately after delivery. So a readiness of the child for surgical treatment of delivery will be made by making prenatal diagnosis. So prenatal diagnosis can be made by an ultrasound or and there are recommendations to do at this first time scanning. We can diagnose different conditions like anencephaly. So you can this one, for example, this baby has anencephaly or encephalocele, which is less likely to survive after delivery, diagnosed at 12 plus 3 weeks of gestational age. And we can see different part of the body of the baby to 30 weeks of 30 plus 6 weeks of gestational age. You can diagnose an encephaly, spina bifida, hollow prosencephaly can be diagnosed in the first trimester. In addition to the in addition to the congenital anomalies, there are also diagnostic model for features of aneuploidies. For example, if the nuchal transparency is increased, absence of nasal bone, tricuspid regurgitation in the first trimester, and the ductal venosus Doppler abnormality in the first trimester will suggest that there is an aneuploidy. So it indicated to test another test like genetics. So here, for example, you can see first trimester nuchal translucency labs, that is cystic high growth and a different trisomy, especially trisomy 21. Here you can see an encephaly in the first gestational age. So ISO recommend this to do first trimester scanning. So we can scan first trimester between 11 weeks of to 30 weeks of plus 60 days of pregnancy, so that we can detect the majority of anomalies that can be detected in the first trimester, and we can provide counseling or in utero treatment or option of the termination for a family. So based on the decisions the family made, you can proceed with decision. And the other trimester scanning is anatomical study or anatomical scanning that will be done in the second trimester between 18 to 20 weeks of gestational age. And in this 18 to 20 weeks of gestational age, almost all that means congenitally abnormal body formation by the external force like oligodynamic dislocation or disruption like amniotic band syndrome can be diagnosed at this early gestational age. That means 18 to 20 weeks of gestational age. So, and we can also look for soft markers that's in the second trimester anatomical scanning. After finding congenital anomaly, for example, in CNS, you may find ventriculomegaly or hydrocephalus, holoprosencephaly, absent corpus callosum. On face, you can see cleft lip, neck masses, and cystic hygroma. And majority of the congenital heart disease also can be diagnosed by 80 to 20 weeks of gestation. After diagnosing this, the second trimester, you give the family a time to discuss, so that you tell them the finding, then we discuss together, and then we discuss about the option of treatment or option to the baby. Okay, so congenital deformed hernia can be treated intrauterine. Congenital neural tube or spina bifida can be treated intrauterine. So we give them the option if that option is available in that country. So that's why we do ultrasound in second trimester and in the first trimester scanning. So as I've said, it's good to have prenatal. What we need is different types of ultrasound machine. So with the old type of ultrasound machine with poor resolution, it may be difficult to diagnose anomalies. But if we have a good equipment, a good machine that can show different structures intra-uterine by using that, and machine, we may need also fetal MRI, especially if you consider there are abnormal good option or a good better resolution than the ultrasound, so we can use for detailed structural analysis of the fetal CNS. Only the machine that we need, we also need an expert that can assess or that can look to the scanning or that can diagnose the fetal anomalies in intrauterine or prenatally. So this expert is, we call them maternal fetal medicine or fetal medicine specialists. Gynecologists and the radiologists also can do can look for the majority of the anomalies, but some maybe need an details of the internal fetal organ. So this is a fetal medicine specialist or maternal fetal medicine specialist. And we also need non-invasive prenatal testing for diagnosis of or for suspicion of the genetics. In addition to the NIP test, if you are finding from the NIP test or if there's any suspicion of the genetic abnormality by ultrasound, that's using the soft markers on ultrasound. So if we are saying that, if you can diagnose with this one, what are the challenges in really in Sub-Saharan African countries? One is the ANC follow-up. Okay, for example, if you take Ethiopia, only 74% of women had one ANC visit or one ANC follow-up, and while only 40% of them had 4 ANC follow-up from the Ethiopian EDHS 2019. So one, there's no ANC follow-up. Even if they have ANC follow-up, the other issue is the quality of ANC follow-up. They may go to the local center or they may go to the midwife and they may have an injection or they may go for vaccination, but the detailed discussion about what's ANC, fetal ultrasound scanning will not be done. So that's another quality issue for those who have ANC follow-up. And the other actual problem in Sub-Saharan African countries, lack of competent ultrasound, MRI, NPIT, and geneticists are not available in majority of health facilities in Sub-Saharan African countries. Even if we of the facility, the resolution and the function of these machines are very poor. And the best one are limited to the major cities and the referral institutions. Expert in also in only few fetal medicine experts are found in Sub-Saharan African countries. For example, if you take Ethiopia, we have only 23 maternal fetal medicine specialists for 120 million population. And the other issue is in Sub-Saharan African countries, for those who has abnormal find or fetal abnormal finding. My sister has presented earlier what the woman feels, what emotional effect has. Poor counseling is one of the role in Sub-Saharan African countries. Majority has home delivery. For example, in Ethiopia, only 48% had institutional delivery. And from this 48%, still majority has will deliver at the lower institutional level where diagnosis of this birth defect may be missed. And in this lower institutions, lack of knowledge and the skill in diagnosis of birth defect among major is one of the challenge that will lead to the failure to diagnose of this birth defect. And days and the burying before the detailed examination of the baby also one of the challenge to diagnose birth defect in Sub-Saharan African countries. As I said earlier, congenital development hernia can be treated in time, pleural effusion can be treated. Immediate newborn treatments like duodenal meningomyelocele, still CDH or congenital development hernia can be done. And infant treatment like congenital heart disease, clubfoot can be during the infancy neonatal period. So what's needed for the management of this congenital anomaly is one, ultrasound with the best resolution, two, expert with intrathecal therapy, three, expert in newborn treatment, and other good neonatal care and good child care centers for those who have the morbidity. So what are the challenges in our setup in the Southern African? One, failure to diagnose, as I've mentioned. Two, lack of, if we don't diagnose, treat. Okay, so for treatment, okay, so as I've mentioned earlier, ultrasound, MRI, and there are also fetal catheters that can be used intrauterine. Lab should be available to treat intrauterine. And no expertise to treat intrauterine, even if we have the machine. So there's also no little expertise in Sub-Saharan African country to treat intrauterine. For example, spina bifida repair intrauterine is not available. Fetal in is not available in Sub-Saharan African countries. And after delivery, this means they need support system, okay, like mechanical ventilation, ECMO, may be needed for those treated intrauterine treated babies. So it's not readily available in African countries. That makes the challenge of birth defect treatment. So how do we overcome the birth defect diagnosis and the treatment in Sub-Saharan African country? One is to increase ANC coverage, and not only the number or the, so we should also increase the quality of the ANC in Sub-Saharan African countries. Second, increasing institutional delivery. So as I've mentioned, it's low, especially as I mentioned an example in Ethiopia, 48%. It's very low, having institutional delivery. So to increase will help us to diagnose and treat as well. And three, and four, capacity building of infrastructure, and the other fifth is registration system for congenital anomalies registration, as well as surveillance system should be available in Sub-Saharan African countries. And improving the research gap in congenital anomalies will improve the challenges in birth defect diagnosis and in management as well. So this all from my side. Thank you very much for your attention.
Thank you, Dr. Tadesse, for your nice and informative presentation. Now we will go for the question and answer. We have one question, and all the panelists feel free to unmute yourself and answer the questions. So the first question we have is, can experts on fetal medicine located elsewhere in the world support in the remote analysis and diagnosis of the ultrasound data collected, and also in the delivery of training to healthcare professionals using remote tools and training as we are using now? I think she means by this webinar. So what's your take on this? I think it's more directed to Dr. Tadesse.
Okay, thank you. So in maternal fetal experts in maternal fetal medicine, even though we have the specialists in maternal fetal medicine, and we are as a infancy or neonatal, but even though we have experts, they are still lacking. We are lacking behind in machines. We are good at diagnosis, but we are not good at treatment.
Okay, thank you. But you were breaking and we haven't heard much of what you were saying. So you can type your answer on the chat box. In the meantime, we can go to the other speakers if you have any say on the matter for experts on fetal medicine located elsewhere in the world and supporting remote analysis and diagnosis of the ultrasound data.
Okay, I know like in our hospital, we have a fetal-maternal program that is being run in collaboration with a university in Toronto, and they actually support the Kenyan, at Eldoret, they support the fetal-maternal specialist at Eldoret. So it's possible to do like the ultrasounds in Kenya and be able, in terms of data security, manage the issues of data security and integrity then before transmitting it to be able to, they're using a cloud-like web thing that they're using, that they're able to collaborate with those experts. So I know that is possible.
Thank you. People are asking questions in the chat box. It's better if you could move your questions in the question and answer feature in your in the bottom of your screen. In the meantime, while I'm seeing the questions, Emma, you can continue. I think you have raised your hand.
Hi, yes, thanks very much. Thanks for some excellent presentations. My question is directed at the speakers who presented qualitative data. Sorry, I've lost my train of thought. How do the findings in Kenya and in Uganda compare with those internationally? Are the feelings from parents and healthcare workers similar? I mean, because there's some sort of consistent themes across the experiences that people have, and I wonder if our experiences in Africa, Sub-Saharan Africa, are similar to those elsewhere in the world. Thanks.
Okay, thank you, Emma. I know we did a literature search, and at some point we decided to use mostly African data. It's because a few things were tying together in terms of the feelings, but what we found is that people, participants from some studies that have been done outside of Africa, they were more prepared by the time the baby was being born because they had early diagnosis, they have access to early ultrasound, they have access to genetics counselors, which we don't have. So in terms of the experiences of the caregivers, it was a bit different. But if you look at the studies around Africa, the experiences around are almost similar. And it's because, and I think then it tells us the gaps we have in terms of early care, early diagnosis, in terms of the gaps we have in terms of early intervention, and the gaps we have in terms of specialists, and also just having a concrete diagnosis. Because some of them, like, apart from the ones we had obvious, like cleft lip and hydrocephalus, the others that had were syndromic, and we couldn't like tell exactly, and those, you could feel the frustration of the parents that they wish they knew exactly what it is, and that's something people in other countries are able to know, but most of us who don't have genetic tests that can support our treatment, then the frustration is different. And in terms of, that's why I think from what we say, we from the conclusion we come up, it has to be a more contextualized model that actually answers more of a Sub-Saharan African and an African problem, as opposed to more something that is more global. Yeah.
Okay, if our other speakers don't have anything to add, we have Dr. Tadesse has written there are fetal medicine experts and webinars. You can join the webinars and you can join it, and you can talk to these experts. Thank you. And Veronica has said that there is a large gap and paucity of specialists in prenatal fetal assessment through ultrasound, and little effort has been made to improve capacity of these key personnel. Thank you. So the other question that have been raised is, how long can it take to find barrier and facilitators in a study? So I'm not sure if this is directly related to any of the speakers, but feel free to answer it.
I think,
No,
I mean,
okay.
that's quite a broad question, and I think that refers to study design. So when you're conceptualizing a project, you would have a research question, and that may or may not contain an investigation of facilitators and barriers. and then your study would need to be designed asking questions or looking for evidence based on literature from other places in terms of barriers and facilitators to try and if you hypothesize that transport is a barrier, then you design your study to be able to address that question. So it depends on the study hypothesis and how you structure your study. If one's trying to generate hypotheses, then smaller qualitative studies might be useful where you get direct input. But I think it's not going to be the same. It really depends on your research question and your hypothesis. Thanks.
Okay, thank you, Emma. The other question is, are these anomalies directly related to the genetics of the Sub-Saharan African population, or is it related to other extrinsic factors?
I think I can answer the question. Basically, congenital anomalies occur from a complex interplay of genetic factors and environmental factors, right, within any population. So even for Sub-Saharan Africa, genetics has a role to play, and also exposure to also the environmental factors like maternal nutrition, and like, for example, neural tube defects has a very strong link to folate deficiency in our official cleft as well. And exposure to infections. There's some viral infections that have been known to result in congenital anomalies in children and some syndromes. And then also exposure to medications, drugs, traditional herbal concoctions. So they all work together to result in congenital anomalies. Thank you.
Thank you. So our next question is, what do we do after diagnosing that the infant has a congenital anomaly under ultrasound? For example, if you find that an infant has a spina bifida or anencephaly, what is to be done at this time? And I want to relate this question with how do you see our cultural beliefs with the diagnosis of this birth defects, for instance, if it is in Africa, we have strong cultural and religious beliefs that such kind of things happen because of a punishment from God. So how do you see this from your personal experience, telling parents that their child has a congenital birth defect and it has to be terminated? Because one of the options is to terminate the pregnancy before it reaches term. So how do you see that?
Again, I can speak to that as a pediatric surgeon who is involved in multidisciplinary care of neonates with congenital anomalies. So first of all, what is done depends on the level of the facility and the expertise that is available at that facility. So if the person who is making the diagnosis, the facility does not have the capacity to handle that particular congenital anomaly, I mean, what is ultimately going to happen is that baby has to be referred to a higher level of care where that can be taken care of. But once it is detected, there has to be counseling of the parents. And at every point in time, a healthcare worker has a contact with a parent who is expecting a child with a congenital anomaly. There has to be detailed counseling. The ultimate decision on what to do rests on the parent. And the healthcare worker does not impose what he thinks on the parent. You generally counsel the parents and give them all the options available and the outcomes of each option and each decision that they make. Ultimately, they decide what they want to do, whether they want to terminate the pregnancy or they want to carry the pregnancy all the way to term. But then if the facility does not have the capacity to manage that particular congenital anomaly, then they have to refer with every investigation that has been done in that facility and with a proper referral notes to the facility that they're referring to. And then ultimately, for most of these anomalies, especially where there are multiple congenital anomalies, it ends up being a multidisciplinary care, which would involve, even at the time of receipt of the baby at the referral hospital, both the maternal specialist, the pediatric surgeons, and every other specialty that may be involved, depending on what kind of congenital anomaly the child may have. right? So I think I hope that answers the question.
Okay, Doctor. Thank you, Dr. Justina. Dr. Tadesse, you can continue.
So Justin already mentioned, so it's whenever we get this type of anomalies, we discuss with the family. Okay, we discuss what's the disease, what's the problem, and what are the options of management. Is it lethal? We discuss everything with the family. Then after, based on the family decision, either with the delivery of going to the term, if it's meant to go term, and so we discuss with them, we give the option, and if she's that's what we do. It's a default situation for a family to handle that. And previously, facing
Dr. Tadesse, we're losing you.
the community now accepted that this is because of folic acid deficiency and it can be prevented. So we have discussed this.
I think Dr. Tadesse has left the meeting. So let's continue with the next question that says, is it ethical to advise parent for termination of pregnancy if identified prenatally, considering the effects it bears on the family and healthcare?
Okay, maybe I can just answer that. That is something that is currently happening, but once, especially with the growing fetal maternal care, once the diagnosis has been made antenatally, the parent is usually are called, like pediatricians and neonatologists, to just give the possible prognosis. And once you agree on the possible prognosis, whether the survival is there or not, and what are the long-term outcomes, then the parent is given that choice. And once they're given that choice, it's ethical, actually, when you think about it, and based on respecting their religious and cultural beliefs. So you offer it and then let them make that decision. And then once you have respected that, and once they have accepted, then you are able to provide that. The fetal maternal specialists usually are able to provide the option of termination of care, basically just respecting the parent's decision. If they don't opt for it, you let them to go up to term, and then sometimes, most of the time, if it's severe congenital anomaly, the child will die in utero or just immediately after birth. So we just let it be a term.
Okay, thank you, Doctor. The other question is, many congenital defects have antenatal signs like intrauterine growth restriction, polydramnios, and especially neural defects. So would there be a value in using some other clinical markers in view of lack of ultrasound and genetics?
So I guess in terms of, you can't use intrauterine growth restriction only, and or just polyhydramnios to say that this is a congenital anomaly, because we know there are many other causes of intrauterine growth restriction that could be either because of an infection, it could either be because of genetic constituency of that patient, that they are just genetically small, it could be because of maternal nutrition. So it's hard to say just based on clinical findings. So it's either ultrasound or you do genetic studies, and after doing amniocentesis and the rest, which is even more invasive. So I think just looking at polyhydramnios, which again, you have to do an ultrasound to actually make that diagnosis of polyhydramnios. So either way, you would have done an ultrasound. Even the diagnosis of IUGR, it's probably you have made it after an ultrasound. So either way, we will need to do some ultrasound to be able to conclusively say that there is an anatomical abnormality. And then you can also do like genetic studies based on whether there's a history of a previous child with a genetic problem. Then you're able to do amniocentesis and do sampling from that and be able to do those genetic tests.
Okay, thank you. So our another question is, apart from genetics, what else are the causes of congenital anomalies in Sub-Saharan Africa? If any, what can we do to eradicate these cases caused by them?
I think I had previously mentioned that besides genetics, we have environmental factors like maternal nutrition, exposure to medications and infections, right? So one of the public health interventions that has really worked is supplementation, for the supplementation for women of childbearing age, right? And I know there's been a drive to shift from saying when the woman gets pregnant, because by the time some of these women know they're pregnant, the child already has the congenital anomaly. So giving the folate at that time is not really going to help, right? So it's ensuring that, there's adequate levels of these even before for the woman who's of childbearing age. And then also, of course, proper nutrition, and then avoiding herbal concoctions. That's one major, significant in Sub-Saharan Africa that also causes congenital anomalies in children. Have a lot of mothers with babies that have congenital anomalies that have been taking herbal concoction that they don't know the contents. The drug could be teratogenic. They could contain some hormones, right, that could also impact on the development of the child, like children that sometimes come up with sort of sexual differentiation. Then prevention of infection as well. So those are some public health initiatives that could be done to reduce the incidence of congenital anomalies. And of course, that also speaks to community engagement, because people need to know that these are the things that could result in congenital anomaly. They have to be educated at the grassroots to avoid all of this and to know what to do to ensure that they have a healthy baby ultimately, right? And of course, again, sometimes everything is just in place and the child develops a congenital anomaly. That happens. So, thank you.
Okay, thank you, Dr. Justina. Do you have anything to add, Dr. Audrey? I think
Maybe
you
I
have
can say, and I think Emma is big on drugs and pharmacovigilance, so I probably should make that comment, but it's something really that we really need to look at, so that we are actually advising both healthcare providers not to give drugs indiscriminately without thinking what are the potential during pregnancy, what are the potential toxicities to the fetus, and also just having a lot of pharmacovigilance studies also just keep going on, and post-market surveys that are going on. But the other thing is also to just remember substance abuse actually, and I think because of in Kenya we say the younger generation, but I think it's anyone who can actually be having other substance abuses that are not necessarily drugs or herbal medication, that could be other things like alcohol and other things during pregnancy, and I think that's important. But I think as Dr. Justina already said, it's actually a multifactorial. You can't say that it's one thing. Yeah.
Okay, thank you. I would like to raise a question as well. So during your presentation, you have raised community engagement as one of the maybe community lack of awareness in the community as one of the barriers for management and even for diagnosis. So how can we engage community that would lead to early diagnosis and management of birth defects? So from your research, from your practical experience, you can answer this.
So was that directed to me, Samrawit?
Any of you can answer. You have said that both Justina and Joyce, I think, probably have raised one way or the other the community engagement as part of presentation. So how would you see that? Because now we are having problems in the community as the people with mothers giving birth to a child with congenital birth defect will be stigmatized and will think that the person is cursed, so they're forced to hide the child and not bring him to the hospital. Because I have experience in the clinics as well. So how do you see that, and how can we change that? Because now we have talked about barriers to diagnosis and screening. I mean, screening for diagnosis and then management. So how can you see this changing and being a solution for addressing it?
Essentially, what has been done in Nigeria, where I have my practice, is grassroots advocacy, right? So going to the community, that's not within the hospital. Now you have to go out to where the people are and speaking with them in town hall discussions, and also in sometimes in marketplaces, talking to people, and just sometimes in religious houses, in schools, just engaging the community in workplaces as much as you can and letting them know about these conditions and the fact that these are the things that actually cause them, not what people assume, right? It's witchcraft, it's something the person didn't know. These are actually medical conditions that are not the fault of anyone, and making sure that it's delivered in a way that the community can understand, engage with, and work with. And I can give an example of, what has also happened is associations, professional associations have partnered with non-governmental organizations to do a lot of this media advocacy, right? So I don't want to start calling names of organization, but a particular organization that's involved in orofacial clefts, right, is one that I know actually does a lot of grassroots advocacy. And you actually have patients being referred as a result of that advocacy. And you have people bringing out their children for treatment, children that they have hidden in the house and they've not allowed to come out for years. They bring them out for treatment following those kind of advocacy, and you have communities being more accepting of these conditions, right? It's not, due to some spiritual attack or something that the child actually has that particular condition. And another way is that for us, for example, in Nigeria, in our national surgical plan, we have included children's surgery as a specific component. And part of the things that is being done for the plan is media advocacy. And in that media advocacy, again, we have that, deeply ingrained to ensure that people are getting to learn about congenital anomalies, to know that, look, these things are not, these are the actual causes, and this is how there's treatment available for it. This is how you can access it. These are organizations that provide the care free if they are actually available, right? And also engaging with primary healthcare workers. And one of the things, again, we're planning to do is to engage with traditional birth attendants, because there's a study that says even in a city like Lagos, up to 50% of mothers actually have their babies with traditional birth attendants and not in the mainstream hospitals. So engaging them as well, so that they can actually take the messaging on to these people that need to hear it and need to know about it, because they are actually closer to the community and they have a level of trust that sometimes these people don't have for the mainstream healthcare system. So I think I'll just stop there. Thank you.
Thank you. So, Joyce, do you have anything to say?
Yeah, thank you very much. Just to add on what my colleague has said, we are anticipating, because very many people are not aware about these birth defects. We are trying maybe to make them aware first and foremost. When they are aware of these birth defects, maybe we can put in place interventions to help them know the causes, the prevention, and the rest of it. And we're also trying to make sure that we engage other, especially the Ministry of Health stakeholders, because as we move along, making sure that we are making them aware, at least we can use the existing services like outreaches and those other clinics or mobile clinics to make sure that people are aware about the birth defects, and so that the community at least gets an insight of what is happening, and then we maybe even provide interventions that can promote these awareness campaigns. Because the reality is that this is a barrier, and since even the babies are being hidden, so we still have a long way to go to make sure, and maybe that is the next intervention that we are going to look at, and maybe even helping and supporting these people who are having issues with birth defects. Thank you.
Thank you, Joyce. Audrey, Dr. Audrey, do you have anything more to add?
Okay.
I guess we are in our last minutes.
It's something we learned from just doing the interviews. One of the participants said she would like to be a champion because of what she's gone through. And I think it's something we can use, just using the people who've gone through it to be able to champion it in the community. And she even said she can do it as a volunteer. And I looked at, and the other day we were having World Prematurity Day, and as I was finishing up this manuscript, I was thinking, why can't we have a World Congenital Anomaly Day, so that these champions can also come out and we can have sensitization throughout, so that everyone knows the congenital anomalies are there and they affect the children, and it contributes significantly to their, not only to their family, to themselves, so that it contributes to mortality and morbidity, but also affects their families, and people are aware that they need support. Yeah, I think.
Can I just say World Congenital Anomalies, or they call it World Birth Defect Day, is 3rd of March. Yeah.
Okay, so we can use those opportunities. Thanks.
Thank you. So what I wanted to add on the community engagement is that, you know, if we teach 1% and that 1% goes to another person, then we create a chain that would, just pass on the knowledge or the information that we want the community to know, so that every child that has a birth defect and that has not been treated and has been hidden at home can be treated. So because today's talk is about early diagnosis and management, and the barriers and how we can address them. So I think our time is up. We have 2 more questions, but we can address them in another way. And thank you so much, all of our speakers, for being here today and giving this informative and engaging work of yours. I'd like to extend my sincere gratitude to you all. I hope and to all our participants who have been attending this webinar. And thank you, Emma and Scan, for inviting me to chair this very informative webinar. And we have Sub-Saharan African Congenital Anomalies Network website where there is a knowledge hub. If you have not gone to it yet, we have the link here, and it will also be put in the chat box, so you can go and check it out. Thank you all for being here, and have a nice day.
Thanks, everyone.
Thanks, everyone.
Thank you. Bye.